Hello, everyone.
Hi, Rich.
Hello, Dr. Barrett. Sorry, my camera has decided to die today. I'll take it out. And I think we've got some feedback. Can everyone hear me okay?
Yeah.
Cool. Okay. Well, thanks everyone for coming. Greatly appreciated. Today, as I mentioned in our Slack channel, we have a consultant hematologist by the name of Dr. Neil Barrett, who's come today just to share his insights about the disease that we are attempting to diagnose, acute lymphoblastic leukemia. Now, I have given Dr. Barrett some information about what we're trying to achieve with machine learning and artificial intelligence. And you know, it is quite an exciting project, and there's a lot we can all learn from it. But of course, we are not experts in the medical industry by any measure. So I think having a more deeper understanding of the disease that we're trying to diagnose using blood cell images would be beneficial, not only for our personal understanding, but also we could apply some insights to develop a better model, perhaps. So as Dr. Barrett's time is limited, do you want to make a start?
Yeah, I do. I'm just trying to share my screen there.
Have you got permissions for it? Then you should be able to do that.
I'm not sure the positions are on my end because I'm so sorry.
That's okay.
We don't use Zoom an awful lot. We have to use our own computers as well.
There's always tech issues when you need them.
Yeah.
You know what I mean? It's always the way. My camera
doesn't
work.
Come back into the meeting the second there. I've just
yeah. Cool.
All right, I think we have it now. Okay. Sorry, I just had to change my security settings.
Yep, got it. We can see it.
That PowerPoint.
Yep.
Okay. Right. Slideshow from. Right. So just going to talk a bit about in the background diagnosis about acute lymphoblastic leukemia, and having spoken to Rich, I'm going to kind of focus on how we diagnose it and how it presents and how it actually works. You know what it is. So it's you know, in really simple, basic terms, is a cancerous overgrowth of immature lymphocyte progenitors. A progenitor means a precursor to the mature lymphocytes. So cells in the bone marrow start off as undifferentiated cells or stem cells, and these go through various stages of maturation to become mature, functioning blood cells. And it can be a lot of these cancers and leukemias occur because of a blockage of one stage of differentiation that's immature, and because of that blockage, everything backs up, like almost like a pipe that has a blockage in it, and everything backs up at an earlier stage. And of course, these cells aren't mature, so they're not functioning correctly. So it causes resources of a healthy marrow to be taken over by this one particular cell type. It's the most common cancer in childhood, and it's 30% of all childhood cancers, approximately 30 per million per year, which doesn't sound like a lot, but in the UK, it's about 400 cases. In Ireland, we're about 40 to 50 cases, and most common between ages of 2 and 5 years old. So quite young children really involved here. Can you hear me? Can you hear me?
Yep.
Yes, perfect.
So leukemia and lymphoma, sometimes you might see acute lymphoblastic leukemia and acute lymphoblastic lymphoma. They're kind of two sides of the same coin, in really that all the difference is a technical aspect about bone marrow involvement. So it's called lymphoma if less than 20% of the bone marrow cells are the leukemia cells. And they're usually associated with enlargement of the lymph nodes or lymphoid organs, and they are the thymus, which is in the neck and behind the chest, which we only really have in childhood. The lymph glands, which people would know as the glands when they've got a throat infection or they've got some EBV or glandular fever, they might have had them enlarged, and the spleen, which is an organ just both side the stomach on the left-hand side of the body, which is not usually something you can feel, but you might feel it in someone with acute lymphoblastic leukemia or lymphoma. And lymphoblastic leukemia, it's called, if more than 20% of the nucleated bone marrow cells, that doesn't include the red cells, are what we call the blasts. And it's usually not even close to 20%. It's usually 90% or more. And there's an image there from a bone marrow with exactly that. But biologically, these are the same disease. But I suppose for your purposes to know that most children with acute lymphoblastic leukemia will have circulating blasts, i.e. those cells can be seen in the peripheral blood before we're bringing them for a diagnosis. So there's something to find. So the presentation symptoms are really about what you have too much of and what you have too little. And the too much side, we call it proliferative symptoms. And that could be the high white cell count. So the white cells are too much. They're the immature blasts, and they're at very high levels. They can be up into the thousands, and a normal white cell count is probably 5 to 10. But in a child with acute lymphoblastic leukemia, it can be anything from low to into the several thousands, 2,000-3,000 I've seen as high as. And what that would mean is that the blood is very viscous from the cells being present, very sticky. So like pumping treacle through veins instead of free-flowing blood. And that can cause stagnation of blood in critical systems like the brain. And that can even cause a stroke. Enlargement of the lymph node organs like the lymph glands, and they could press in structures. And if you can have lymph node glands in your neck, you could imagine that could affect your airway, and that could be very serious. And the thymus, which is inside the chest, obviously there's critical structures in the chest, so it can compress the airway, the lungs, or the heart, or all three, and that can be really quite life-threatening. The other symptoms they get is bony pain, and that's from actually expansion of the marrow with leukemia. So the bone marrow inside the bone is actually expanding, and they get pain and aches from that. And the child who doesn't what runs around wants to be picked up and held and cuddled instead of running about the place. And fever. So that's consequence of the metabolic turnover of these cells are really rapidly proliferating, and the so-called B symptoms, which are fever, night sweats, and weight loss that can be associated with any lymphoid malignancy. The other things it causes is what you have too little of, because like I said, they're weeds in a flower bed and they're outcompeting the normal cells. So if you're outcompeting the normal cells, you have less of the normal cells. So less red cells gives you anemia, and that can make you tired and pale. But it can also lead you into actually having high output cardiac failure. So they actually come in really fast heart rates, really shook, really struggling from a cardiac point of view. Get infections because their blood cells, while they might have high blood white cells, they don't have functioning white cells, and therefore they're vulnerable to infection. And the last type of blood component in your blood are the platelets, and they're like little sticky things that go around and they plug up holes every time you have a bleed. And that can lead to a lack of those can cause bleeding and bruising and something called petechiae, which are little pinpoint hemorrhages. And these are the little hemorrhages that we're told to look out for when such a child might have meningitis, and that they don't blanch under pressure. The tumbler test is the thing that everyone is taught, and every parent has probably seen those ads. So our diagnosis really is based on first of all, our clinical suspicion, and almost all the cases will have one of those symptoms. And because children don't have routine blood, so they don't go see their GP and say, can I just get some routine bloods off and get a needle in the GP, and they send it in. Kids only really get blood tests if there's something wrong with them. They've come to the ED with a high fever, or they've had unexplained bruising or bleeding and there's concern about it, or they've had the petechiae with the tumbler test and they're worried about meningitis. So there's always some sort of clinical suspicion. And from that then, the first test is the full blood count, or FBC as they call it. And in America, you might have heard in ER, CBC and Chem7, the CBC is complete blood count, they're the same test. And that basically looks at the numbers and types of blood cells that you have, and basically the hemoglobin, the platelets, and the white cells. And most of those will have an abnormality in patients who will eventually be diagnosed with a leukemia. And this goes to the concept of using those clinical and basic test routines as part of your prior probability or probability testing. We use automated analyzers in most modern countries. The older systems use electrical impedance, which I'll put a slide just for reference on the next one, which just looks like electrical passing through the cells and judges cells by their size and complexity based on that. But the more modern systems, certainly that we have here, are using light scatter, which kind of change, so the content of the cell and the size of the cell will just. Hi, can you hear me? Will determine. Okay, so the light scatter will change the pace on the cell's content and size, and fluorescence using a dye that screens the nucleus will also tell you about the size of the nucleus and the size of the nucleus related to the cell, and that's important for that ratio. And actually the machine will actually spit out a series of plots that you can see here in this slide. And the plots will kind of roughly tell you the type of cells that we're dealing with. And in fact, for blast cells, we'll actually have kind of a characteristic location where they might be. In this case, in this, what we call the WDF and the side scatter, they would actually be located here. So we can actually test up what we call a blast flag if we see cells that on that criteria alone are suspicious. I'll just leave this slide here, and I don't want to labor on it because it's quite technical, and that's just about the technologies themselves. And I'll just leave it here for interest, and I'll provide a PowerPoint to Rich at some point. You can distribute it for your learning. But our lab, and we're kind of lucky, and it's relatively few places to have it, does have kind of a optical system where some based on certain triggers and the full blood count, that some of the slides are made automatically, and the machine will attempt to identify cells in them. And this is actually cells from a leukemic patient who had a very low percentage of blasts, and it has identified some cells there as normal lymphocytes in the top group, some monocytes. It's attempted to identify large platelets here, and it's put out a cell that it thought might be a blast. I'll be honest with you, you wouldn't be terribly moved by one blast on it. So, and this cell isn't particularly convincing for it, but it did identify it. Subsequently, in this patient, we identified a 4% blast population by flow cytometry. And this patient was very much the exception rather than the rule, because this patient kind of lacked any changes in their counts other than their mild reduction in their white cell counts that was really of concern. But there was clinical suspicion in this child in that they presented with a significant history of fairly convincing bony pain, and that's what prompted it. So here the clinical component was what prompted us to do the further testing, even though it probably would have got in a pass through by the Mark 1 eyeball and even this cell-vision machine, with finding only one cell of concern. So obviously in this case, it might have been useful to have a better system automated. So following a initial full blood count and the clinical assessment, the next thing we do is look at the blood underneath the microscope. And microscopes are expensive, but widely available, need to be well maintained. But you can certainly see lots on them with an expert eye. And here is a slide here with two blast cells and a normal band neutrophil that the patient who had an ALL. In fact, these are the L1 blasts, and I saw Rich commented on someone sharing a slide of the L1, L2, and L3 blasts. which you're about to see, actually. So this is an L1 blast in the film that we picked up. This is a patient from mine about 5 or 7 years ago, actually. So morphologically, when we're looking down the microscope, within ALL, the blasts have 3 different types. The L1s are the hardest ones to see because they most look like normal lymphocytes, kind of nondescript, and we call a high NC ratio, nuclear cytoplasmic ratio. That means the nucleuses are as big as the cytoplasm. They're close in size, so there's not a lot of spare cytoplasm to begin with. The L2s are a bit larger and more heterogeneous. That means that there's more variation in them, but they can have abnormal nuclear folding, kind of a 3-dimensional nucleus, and occasionally nucleoli. Nucleoli are where ribosomes are made, and they kind of look like kind of little bubbles within the nucleus, but not like bubbles like aero bubbles or clear bubbles. They're kind of just a little bit lighter than the nucleus itself. And the L3 blasts, which are kind of more obvious, and these are the ones that are very large and kind of aero bar type bubbles in them, but mainly in the cytoplasm, but also in the nucleus. And I have 2 pictures here from actual patients as well, with permission, that includes these findings. So here's an L2 blast. These are from bone marrow, so there was plenty of cells to look at. You'll notice there's often a bit of crossover. There's, a bit of mixture of the L2, L3, and L1 types within one patient, and that's just the reality of it, but usually one predominates. So in this one, you have the L2 blasts. You can see they're a little bit larger than the ones you've seen before. The NC ratio is still high. To me, that they have an open chromatin profile, which means they're kind of a bit more see-through, and occasionally, although this is not a great picture, you might see some sort of 3-dimensional folding in the nuclei. And the next one then is a nicely clear photograph actually showing the L3 type with the vacuoles or aero bar type bubbles within the cytoplasm. And we usually call them L3s or Burkitt-like, and there's plentiful cytoplasm. There's nucleoli in them. This one has 3 nucleoli here. If you can see my arrow, here and here, and maybe possibly here as well in the nucleus. But that to me would be a barn door leukemia, or even a Burkitt's leukemia if the differential. The next slide. Then but really the mainstay of our diagnosis that confirms this is called flow cytometric immunophenotyping. And this is basically a method where cells are taken under a high hydraulic pressure to be in a linear kind of path through a analyzer, literally 1 cell at a time. The modern flow blood analyzers are essentially our flow cytometers, but with immunophenotyping, what we do is we add dyes, which are antibody labeled dyes, specific proteins that can be on the white cells. And this allows us to actually say what proteins are on those individual cells and determine what combination of proteins, more importantly, are in the individual cells, and use that to identify exactly what they are based on what we know the patterns are. So essentially these produce plots that we can forward and backgate. Forward and backgate means that we can select within different windows and move backwards and forwards to select out a specific population. This slide's a bit busy, but this is what we get. So in the first slide here, we have kind of viable cells and the overall structure. This is based on what we call forward scatter and side scatter, which is basically size and complexity. And we kind of eliminate the red cells, which are all kind of, because they have no nucleus, they don't have a very large size, and they don't have a very large side scatter. So they're kind of lumped up here. Then we look at singlets. Singlets means that the cells aren't stuck together within the cytometer. And then we can look where we call a blast window, which is based on our CD45 and side scatter. And within then we can look at various cell markers, in this case CD19 and CD10, and we can see which combination they are. Obviously double positives are in one quadrant, and negative for one or the other are in the this quadrant or this quadrant, and negative for both are in the quadrant closest to the axis, to the origin. So I'll just show you in a more simpler time point here, and this is flow cytometry. This is shown as a histogram and as a flow plot, and this is a patient who had a CD19 positive population, and within that CD9 gated, so only looking at the CD19 population, I could see they were positive for 79A and TDT, which are markers for ALL. This patient also had some aberrant myeloid markers, which we're able to detect as well. So just really focus on that we have a subgate 8 of CD19 positive, and within those we have markers of primitiveness within them, and these were ALL blasts were shown by flow. So the bone marrow aspirate is then the final stage of our diagnosis. So sometimes the flow can be done on the peripheral blood, and that can identify the blast populations, and it's usually fairly sensitive down to 1 or 2% of the cells. But if there's doubt, we often go for the bone marrow, and the bone marrow will usually tell us one way or the other. So usually we have very high infiltrates of cells. This is actually from the same patient that you saw the L1 blasts in the first slide. And you can see actually that T cells are a little bit bigger in the bone marrow. Some of them even have vacuoles, so it's slightly varied, but you can see it's much more concentrated. And then the next slide is an even more obvious example of a patient actually who had not a lot going on in the peripheral blood. This is the same patient who had the 4% marrow in the peripheral blood, but in the bone marrow themselves, they're completely packed. So almost every cell on this slide is a blast. And in fact, it's easier to show you the ones that aren't. So here is a nucleated red blood cell. And there is, looking at it, there's very little that isn't a blast actually. There's kind of a myeloid cell here. It's a little bit higher. Oh, it's a cytoplasm and it's slightly pinkish in it. There is a metamyelocyte here, which is that kidney bean shaped one, again with a kind of a pinkish cytoplasm around it, and some other nucleated red blood cells here and here with a very round nuclei, kind of pinky blue cytoplasm. But almost everything else is a blast. This is an eosinophil here, but almost everything else. So this is what we call a face to it blasts. And you can see here there's a bit of variation in these subtypes here. You can see some with some vacuolation, but mainly they're L2 blasts for me here. But there is, probably examples of each type within this slide here alone. But the main thing is here when you're looking down is that you're deciding that a lot of anything that's the same is bad. And what you want to see down when you look down on bone marrow is a lot of diversity, a little bit of everything being made in proportion. So this is a bone marrow process where one process is taken over completely. So the diagnosis, having blasts on the peripheral blood doesn't mean you have leukemia. There are other differentials. Acute lymphoblastic leukemia and acute myeloid leukemia being the main two leukemic types. You could have chronic leukemias, but they tend not to have a lot of blasts. You could have myelodysplastic syndromes, myeloproliferative disorders. You can see blasts in normal patients who've had chemotherapy and the bone marrow under stress has just put out cells a little bit early and they look like blasts. Patients who've had granulocyte Connolly signaling factor, which can be in combination with chemotherapy, or patients who are recovering from chemotherapy are having low blood counts for some reason, are artificially stimulated. And patients with leukemioid reactions and occasionally patients with rip-roaring infection will put out cells that look like blasts. And again, so the clinical correlation is required. So I did speak to Rich about what I thought is the scope of these type of processes. Really, the scope, some factors will limit its usefulness, and that one, that the diagnosis is often not very difficult. Two, that the existing technology is relatively good, and the incidental pickups are rare in children with no routine screening. So it's not as if you're going to have just screen every person who's had a GP blood, because there's just not screening of children. The other thing about ALL, being in early at the diagnosis doesn't necessarily mean you're better outcomes, and really because you're battling the biology of disease, and because blood is everywhere, there's no stage. So it's not like a stomach cancer that has stage 1, 2, 3, or 4, depending on local spread. Blood is everywhere, so there's no stage. And there's trade-offs as well if you were to start doing investigations based on a new technology of anxiety and false positives, of worry and unnecessary testing. And of course, children particularly don't like needles, and neither do their parents. They won't thank you for that. But there are aspects where this could be really useful, and that's kind of in the resource limited setting, lower middle income countries. Places that lack flow cytometry, lack expertise for manual diagnosis. And I would say what particularly would be useful for distinguishing ALL from AML. So that's acute lymphoblastic leukemia from acute myeloid leukemia. And that, despite what the first thing you find in Google is actually quite difficult. And there are ways you could do this with a basic light microscope. And I do note you can literally put your phone up to the eyepiece of a microscope and take relatively good pictures. In fact, some of the pictures you're looking at were precisely me doing that with a steady hand. But you can also get like little instruments that are relatively inexpensive to formally connect to the microscope. Even little 3D printed case holders that will do the job for you and hold it nice and steady. So there are ways that those images could be taken if they were to be analyzed by software relatively inexpensively. So I do see it as valuable. On the grail of AML versus ALL, sometimes it is obvious, and this is a patient with AML, and the blasts here are what we call pro-myelocytes and myeloblasts. And their characteristics is their shape of their nucleus. Sometimes we call it bilobed or peanut shaped. And they also have kind of what we call granulations in them. Granulations are almost all, are really make it easy to say it's myeloid if you have these kind of granulations or colored little spots within them. And occasionally you'll get something called an hour rod. Here's an hour rod here, which really only means one thing. It means an acute myeloid leukemia. And that's usually easy, but there are myeloid leukemias. Here's the next slide. That are much more difficult to say whether they're lymphoid or myeloid. And in this one, I don't think you could genuinely call it, because while there are a few cells that kind of look maybe more myeloid to an expert eye, most of them are nondescript. You still have nucleoli, open chromatin, and a high NC ratio. And you could call this as a leukemia, but I don't think anyone could call on a manual basis, be quite certain on their diagnosis that that was an AML or an ALL. Now you'd look at the age profile and known instances, and that would inform your choice and other things. But I think it can be very difficult to make that distinction. So I would hope in your training slides you do use myeloid leukemias as well, just to differentiate it. But of course, the main thing is it leukemia or not? And you can move to more advanced testing depending on what's available. And the other thing I'm going to briefly talk about is just to make sure everyone knows about test properties, about true positives, false positives, concept of sensitivity, specificity, and positive and negative predictive value. And this is kind of the matrix that they use to teach this. So true positive is someone that really has disease. True negative, that really doesn't have the disease. A false negative is someone who tests negative but really does have it. And a false positive is someone who doesn't have disease but does test positive. And there's some concepts that's important. And sensitivity and specificity are characteristics of the test itself, not the population. So it's the test itself. So given that a patient has a disease, probably they will test positive for the disease is their sensitivity. And their specificity is given that they don't have the disease, chances that they will test negative for the disease is their specificity. So specificity is about avoiding false positives, and sensitivity is about not missing cases. So you're not missing a diagnosis. And in different circumstances, you may have different priorities on that. And usually there's a trade-off between sensitivity and specificity. So the more sensitive you are, you're typically less specific. And the more specific you are, typically you're less sensitive. And I know you've all maybe had access to a paper that talks about this and receiver operating curves, which what we're seeing here. So basically, if you had a perfect sensitivity and specificity, you're going to be up here. And if you, and that's where you want to be, this happy side here. But usually you're somewhere in between, and you'll see how things are going. So you're either better or worse than guessing, depending on your sensitivity and specificity. The related concept is positive and predictive value, and this is a post-test probability. And this is about given that you've had a positive or negative test, how likely you are to have actually the disease. So the positive predictability is given a positive screening test, how can you have this, how likely you are to have the disease, and vice versa for the negative predictive value. I'm just conscious of my time here. So really, it's one is cart before the horse and vice versa. So specificity is the likelihoods of positive given the presence of absence of the disease state, and the positive and negative predictive values are the based given the presence or absence of the disease, the results evaluate the likelihood of the presence or absence of disease given the results of the test. So it's after the test that you're evaluating the positive and negative predictive values. So there's a few concepts in there that are kind of what we call Bayesian, really, and I'm sure you guys have probably got better math than I have. So the positive test predictive value is really about the positive tests are actually true. So that over your likelihood of having a positive test. So it's the likelihood that you have a positive test and you test positive over the likelihood of being positive overall, which includes being positive and testing positive and being negative and testing positive as well. So this gets a little bit nuanced here. So if you sub in this formula, you get in this idea of prevalence. Prevalence is the set times the sensitivity is the idea that you'll test positive when you really have it. And that's really key to this concept, because the prevalence is essentially a prior probability. So if tests are true, to be positively predictive, you must be positive and you must test positive. So therefore, the prevalence in the population actually matters. So with sensitivity, it doesn't matter, because by definition within sensitivity, the population you're looking at is 100% positive. So with the positive predictive value, selecting the group you're actually doing the test on matters. So if you select a test group that has high prevalence, your test is likely to be positive, and vice versa for negative predictive value. If it's a very low incidence, your test is likely to be right. So if I said that testing negative is always right, that could mean that the population that you're testing is all negative. So anytime you have a negative test, it's going to be right because your underlying prevalence is 0. If your underlying prevalence was 100%, then all positive tests would be correct. I hope that makes sense. Do study those slides if you don't have a familiarity with this. So we can see if we do what we call prior test probabilities and feeding into our test, we can stack the deck. So if something has a 90% specific and 90% sensitive test and has a 0.1% prior probability, and remember our incidence of ALL in childhood is very low overall. So even with a 90% positivity, the odds of your positive tests being positive are very low. They're under 1%. If you select a subgroup to use to apply the test to, which says has a 10% chance of having a leukemia, then the test becomes very useful. And inverse in the negative as well. So if you're looking for a child who does not have leukemia, you want your negative predictive value to be high. So you're also wanting to stack the deck that way. So I would just have a thought, if I was designing a test like this, I would make sure that the AI has other information if available. And I know maybe that's not the goal of your testing and the goal of your project, but I would maybe once your project is done, see if plugging in that data post priori actually helps your model. So you could say that, you know, if there are other clues, you can stack that deck as well. So, and what I would suggest is that you look for a low positive predictive value. If that's your priority, is to maximize that, you might change your specificity and sensitivity cutoffs depending on your clinical suspicion. So if you think the child might have leukemia based on they come in with bone pain, they've come in with anemia, they have a low platelet count, then you want to prioritize your sensitivity. So you pump up the sensitivity. And even then, if your specificity is very low, your positive predictive value becomes very high. So at 10% prevalence, so the patient has a low platelet count and they've got achy bones, you put your sensitivity up to 9%, but your specificity, you go way down to 10%. Your positive predictive value is still really, really high when you get a positive result in that subpopulation. But obviously, a 10% sensitivity would have a terrible outcome in a general population. So I think you need to think about the context of your test as well. So you could look at that. And again, I know that's maybe not the goal that you have. So in summary, I would say that ALL diagnoses usually occur in the context of symptoms, and that clinical or basic hematological clues prompt further testing. And then expert blood film analysis, and that's really just gained by time and experience, is the starting point. And then we use a flow cytometer, which is a very good technology and sensitive technology for the presence of blasts. I would say to you that not all cases of ALL have circulating blasts. And that is to say, even if your system was perfect at picking out blasts, it wouldn't catch all leukemias because some children don't have circulating blasts. And it's only when we look in the bone marrow that we really see. And you can see that from that example I showed you. So that child with the very high count infiltrate in the bone marrow had a very small infiltrate that we could easily have missed in the peripheral blood, and even could have been absent a week ago. I think this sort of technology would be supplemental in a modern, well-resourced setting, but could be really important in resource-limited settings. And I would just remind you, just when you're thinking about sensitivity and specificity, which you would be setting when you're training the AI, you might deploy those settings of trade-off one versus the other in a different way when that AI is then set on a task to look at a blood count or a blood film on a patient, and plugging in those extra parameters to kind of, to say, should I be innately more suspicious on this review or innately less suspicious? And really thinking about your priorities in each situation. Are your priorities for it to rule out leukemias, or are they priorities to rule it in? And they're very different questions. So I'll thank you for your time, and thanks for Rich for asking me.
Thank you very much, Dr. Barrett. That was great.
That was helpful.
Yep, really, really helpful. I know we've only got, a minute or so left. If I'm sure a couple of the participants will have a few questions, and I'll forward them on to you, and we can, it's save us restarting this call and using up all time, because I know it's limited. But it was truly appreciated.
Yeah, I hope it was. Was it beneficial?
Yeah, it was. It was. I mean, we're using just single blast images, and I think some of the sort of like biological and topological features of themselves will really help in identifying them as well. So it has been time well spent, and if you could get them slides over to me, if that's possible, it'll be great to share them with the participants as well.
I'm just going to make sure I've redacted everything kind of from the metadata, so some of the patient images, just to make sure I've done that.
Cool.
But and I'll get it to you next week, Rich.
Yeah,
but again,
thank you very much.
I understand you're only working with the images, but I think when you're looking at the back end, when you're applying the technology, you probably can use the other data. So I think it's almost, you almost have a handicap here, because
Neil, we'll have to refresh because it's about to run out of time.
Hi, Rich.
There we go. Hi. Zoom just logs you for 45 minutes and then boots you off.
Perfect. Okay. Well, I don't think I have anything more to say, and I know, it's kind of hard to go for an audience where I know I have to keep it basic, but also try and teach you something useful.
Yeah,
So,
no, it was great. It was very thorough, and I think I was making notes along the way, and I think there's a couple of points that you raised in terms of how the lymphoblasts look like in terms of like L1, L2, L3, and whatnot. That can be taken into consideration. A question I had: you said that early treatment doesn't necessarily improve outcomes, but in terms of these cells being L1, L2, L3. Do they dictate any sort of kind of indication of
no,
what the
no
prognosis
clinical
will be?
significance.
Sound okay, perfect.
So there's no prognostic no prognostic association between the different
Cool.
subtypes
Cool.
morphological.
Okay, that's spot on. And I'll just we've got about 3 minutes left. Let's just is anyone who was on the previous call? Does anyone got any questions at all? Put them in the chat or jump on microphone. Go on, Eva.
So, quick question: like the colors that you the cells are having, to what extent they actually determine and help in the diagnosis? Because some could be like a little bit more pinkish, a little bit more. Is the color kind of one of the criteria there?
Well, I think that's another challenge for you because the colors there, and some of that's going to be affected by my white balance. It will, and the staining quality. So you're going to have variations from lab to lab and stainer to stainer. So you can't put a huge amount of significance on that. So even within microscopes within the same lab, depending on their light source, whether they're an LED or a halogen bulb beneath it, you might have differences on the underlying white balance. You'll have differences on the stainer as well, even between runs. So one problem we do have, and particularly in children with high counts, is the morphology might look a little bit washed out if the dye is being spread along a lot of cells. Now, having said that, that's kind of an academic point in the sense that if they're that high anyway, you're just by the sheer number of cells, you're going to have that suspicion. But the color itself is going to be relative, and it's going to be variable and it's one of your challenges really, because depending where the image was taken on the microscope, it was taken, and this particular lab stain, you could have variations that would look different for the exact same slide. So put that in context. Sometimes if you were sending a difficult case, and this wouldn't be ALL, and we call it mild dysplasia, where we have kind of
Oh, I think we might have lost them.
Yeah, it got froze.
Yep, you're back. Sorry, if you can hear me.
Yep, we can hear you.
Sometimes, if we were sending something external, they'd ask us to send an unstained slide so they could stain it in their own stainer. So that is a real challenge for what you're doing, I think, because there will be a heterogeneity in quality of the slide, in quality of this microscope image, and the quality of the stain.
That is a very interesting point, actually, because as you know, the images that we're training our models on have come from one lab, so it might be an idea to maybe find similar images from other labs, which show these kind of differences in the training data, just so we can pick up them kind of differences.
I can almost guarantee you'd look different from lab to lab, and we know we train in lots of different places. We can notice going from one hospital to another that the stainer looks a little bit different in quality. Now, it may not be a huge difference, but you would see differences.
Yeah, no, that's great. That's great. Just final call out: if anyone's got any questions, just jump on mic or pop them into chat.
I would say one thing, if I was to make one point. Color may be not the most important thing. I would always look at the texture of the nucleus and its three-dimensionality. If you're seeing something that looks folded and complex and three-dimensional, that's suspicious.
Cool. Yeah, we've been working with improving the contrast on cells so we can identify.
Yeah, so if you're
that kind
seeing
of thing
signs
as well.
of folding or anything like that, that's a red flag.
Cool. No,
So you
that's great.
call this chromatin or something like that.
So there's chromatin. So chromatin would mean the how the nucleus, how the nuclear material within the nucleus is bundled. So chromatin is how the DNA is packed. So sometimes you might see it kind of very dense nucleus that you don't see any kind of variation in texture or color. And in other cases, and often in blasts, you might see what we call open chromatin. It's almost like looking through net curtains. There's not a hole, but there's kind of an impression of variation within it and texture. So called open chromatins. Fine point. And I suppose this is where a human brain kind of gets to know these things without being able to verbalize. I can tell you that a cell is a blast, but to explain to you, it's kind of hard. But
it looks like depressive, right? Like it's when you look at the blasts, they look like more depressed somehow. Yeah.
Yeah. Because we all started out this, I started the same, like learning this in college, where, oh, these a pink cell, that's a slightly purple cell, and I don't know the difference between any of them. You know, like it's just experience time sitting down with books, looking at examples, and then seeing tons and tons of cases. And you know, it's I'm sure a human brain does it without really thinking about it. It just kind of starts to learn.
So how about the border? Like, is the border any, having
so
more darker
contour
blue?
matters as well. So some cells have regular borders. Now, and a regular outline. So myeloid cells tend to have a bit more variation in their outlines. Lymphoblasts tend to be relatively smooth, and there are some cells that are extremely smooth and very round, and those are like nucleated red cells are, easy to pick out because they're so circular. So there is importance to the outline of the cells, I would say. So yeah, more so than color, I would say.
Yeah, so nucleoli and this chromatin and especially granulation is important for you.
So if you saw granulation in a blast's cytoplasm, so in the non-nucleus, you see granulation in there, that strongly pushes you against it being lymphoid in origin. It kind of puts you down the myeloid route. So if you're seeing myeloids, granulation in that, that's probably not lymphoid origin. We never say never though, and the other thing is it's also about birds of a feather flock together. So if I'm seeing lots of those same cells, that raises suspicion. So, where I see one or two on a blood film, I might allow it to pass. But if I keep seeing the same one that looks a bit samey, sameness is generally bad. So if you look down at that marrow I showed you, all those cells look very similar to me. There's very little diversity. And I should have thought to put up a normal one, because a normal one looks like a zoo of different types of cells. So that sameness alone, I can diagnose that from 20,000 feet, so.
So it's about the percentage of certain a certain same structure. How many
so if you're seeing
percentage?
the same thing again and again.
Yeah.
White patches. So I don't know what white patches. I think the white patches you're talking about what we call vacuoles or bubbles. So vacuolations are usually abnormal. You can see them in activated lymphocytes. So occasionally children with glandular fever, you'll see vacuolations or certain viral infections. But you do see them in the L3 blasts or Burkitt-like blasts. So kind of aerobar white patches or vacuolations, usually abnormal, but not always. You can see them in EBV, Epstein-Barr virus infections or glandular fever as well. But if the nucleus is right, then you're kind of wondering about blasts as well.
You also mentioned that the size of the blast is bigger, right? That's one of the
so
things.
So you have the L3s are the biggest of those, and the L1s are the smallest. But again, you can have a mixture of L1s, L2s, and L3s in a patient, but usually one does predominate. So two examples there, I have L2 and L3 predominate and one with an L1. So, but there can be, it's not biology, it's not usually cut or dry, it's a continuum.
Thank you.
Sorry.
That was great.
Yeah.
Thank you very much. I'm
Okay,
conscious of
Rich.
time now. I don't want to take too much of your day. You've got
Yeah.
important work to do, but yeah, we fully appreciate you spending the time with us and giving us a lot more context.
All right.
You know, I'll be forever in your debt. If you could just get
No
them
problem. Just
slides
reach
over
out
to me.
anytime and we can kind of work
Cool.
on it a bit more.
Yeah,
Happy to do
spot
that.
on.
Okay.
Yeah, that'll be great. That'll
Thank
be
you.
great. I'll put this on YouTube and I'll send you the link as well, Dr. Barrett, and you can check that out.
Thanks
Cheers.
very much. Bye.
All right. Thanks, everyone. Bye-bye.
Thank you. Bye.